During my presentation, I will discuss the clinical practice on managing patients with elevated lipoprotein a. Over the next 15 to 20 minutes, I would like to discuss the following topics. I will first briefly address why we think Lp(a) is a risk factor. Then I would like to discuss drugs that decrease Lp(a) concentrations. Then I will briefly discuss probably the most effective form of treating elevated lipoprotein a, namely lipoprotein apheresis. And then I will show you the therapeutic algorithm that we use in Munich to treat patients with elevated lipoprotein a. As you all know, lipoprotein a is an independent risk factor, but as other risk factors, it also adds in addition or together with other risk factors, meaning that if you have other risk factors and elevated lipoprotein a, that is of course translates into more risk than if you only have elevated lipoprotein a. And that can be seen very nicely here from the data from the Copenhagen group, where you can see that depending on the presence or absence of other risk factors, risk increases with increasing lipoprotein a concentrations. Thus, before deciding whether a patient needs treatment, you have to determine the overall risk in the patient, the overall cardiovascular risk, and you also should try to see what is the lipoprotein a attributable risk. Thus, if that is a patient with diabetes, hypertension, and smoking, then a mildly elevated lipoprotein a is probably not contributing that much to his risk compared to the other risk factors. On the other hand, if you have a patient whose only risk factor is a severely elevated lipoprotein a and who has cardiac disease, then obviously this risk factor, the elevated lipoprotein a, plays an important role. Now, what options do we have to decrease elevated lipoprotein a concentrations? Here you can see that there's a number of drugs and substances and approaches that have been shown to decrease elevated lipoprotein a concentrations. As you can see, there's niacin, there's hormone replacement therapy, there's lipoprotein apheresis, of course, and there's relatively new PCSK9 inhibition, which can also, in addition to decreasing LDL cholesterol, decrease lipoprotein a. And as you can see there's a number of other drugs that are in development, which also, in addition usually to other changes, decrease lipoprotein a. There's mipomersen, an ApoB antisense oligonucleotide, there's CETP inhibition, and then very interesting, there's also ApoA antisense oligonucleotides, which specifically try to address elevated lipoprotein a. Now, on that list, which is a table from a publication a few years ago already, but there you can see that there's actually a number of other compounds that can affect, at least to a certain point, lipoprotein a concentrations. But in summary, all of them have been, to a certain point, disappointing because either the effect was very mild in real life, or if it was tested in a clinical trial, it did not show any benefit with respect to cardiovascular events. Here, for example, are data shown for hormone replacement therapy, and you can see that similar to simvastatin, both actually reduce to a certain point LDL cholesterol, but in addition, hormone replacement therapy could also lower lipoprotein a, but you're probably also aware that hormone replacement therapy is not a good modality to decrease cardiovascular events because there was no benefit in patients treated. Similarly, if you look at niacin, and these are data from the HBS2 Thrive trial, a large trial where niacin was used in combination with larapiprant in order to decrease triglycerides, increase HDL cholesterol, and also decrease lipoprotein a. And in the study, there was a 16% decrease in lipoprotein a, but as you know, the study was negative and there was no no benefit to the patients treated with niacin and laropiprant, which does not mean that lipoprotein(a) reduction does not help. It just means that this is probably not an appropriate approach to decrease lipoprotein(a). Now, very recently, we have seen data on PCSK9, and you can see that there's a dose-dependent reduction of lipoprotein(a) with PCSK9 inhibition. But again, the major effect of PCSK9 is, of course, LDL reduction, and thus it will be probably difficult to dissect what is the role of PCSK9 inhibition in reducing lipoprotein(a) concentrations. Now let me switch to the most effective method to decrease lipoprotein(a) concentrations, namely lipoprotein apheresis. As you probably know, there is a number of studies clearly showing that lipoprotein apheresis can decrease LDL cholesterol concentration by about 60 to 70%. And very similarly, lipoprotein(a) concentrations can also be decreased to approximately the same extent. This is not very surprising because apheresis usually is based on the elimination of ApoB-containing lipoproteins, and lipoprotein(a), just like LDL, contains ApoB and therefore is decreased to a similar extent. Now, there's a number of studies evaluating whether Lp(a) reduction translates into clinical benefit. There's 2 studies which were randomized controlled trials, one showing an effect and the other one showing no clear effect. While both of these studies were not without problems, let's put it this way, because the study that did not show any effect, the apheresis was only performed every 2 weeks, and patients were not selected for high lipoprotein(a) values. Thus, the average value was rather low. On the other hand, the one study that showed an effect did not look at clinical events, but it only showed or evaluated angiographic changes. Now, and there's 3 studies that looked at events retrospectively. Thus, they were basically comparing the event rate before starting apheresis and after starting apheresis. And this is shown here, where you can see that before the apheresis, there was a high number of events, and then after apheresis, the number went down. If you translate that into risk reduction, you can see that there's a dramatic risk reduction, but you have to be a bit careful because it's really looking at events after the initiation of apheresis and comparing it to the period before apheresis. Now, the problem with this approach is that you assume that the event rate would stay stable, thus would remain high even if you, over the next years, even if you do not perform apheresis. In order to highlight the problem with this approach, I would like to use some data from the 4S study. You know, the 4S study, a large study with simvastatin, and the inclusion criteria was that you had to have an event within the last 6 months. So that translates into an event rate of 2 per year. Now, when you look then at the data during this study, you can see a dramatic reduction of 97%. And that was in the placebo group. While in the verum group, in the simvastatin group, there was minus 98%. So in order to really evaluate an effect, you have to have both groups. And that is, for me, a very strong indication that also apheresis may show some benefit. The quantity is unclear, and that we really need a controlled trial in order to see how much benefit apheresis really gets to patients with elevated lipoprotein(a). So what are we doing now with our patients? Well, if patients have an elevated lipoprotein(a) concentration, we determine the overall risk, and then in patients who do not have any atherosclerosis, we try to optimize all risk factors, including and maybe particularly LDL cholesterol. Thus, we try to decrease LDL cholesterol either to below 100 or to below 70 milligrams per deciliter. While in those with atherosclerosis, we primarily use the same approach. We optimize LDL cholesterol, definitely to below 70 milligrams per deciliter, if possible even lower. And if these patients then still show progression of atherosclerosis over 1 year, progression clinically and on angiography, then we consider them for apheresis if simultaneously the alpha-a concentration is above 60 milligrams per deciliter. So let me summarize. I think it's quite clear that lipoprotein(a) is an independent risk factor for cardiovascular disease. Whether or not patients with elevated lipoprotein(a) concentrations need to be treated depends on the overall risk and the lipoprotein(a) attributable risk. And also lipoprotein(a) can be reduced by hormone replacement therapy, niacin, and some other compounds. There are no convincing data that these approaches reduce cardiovascular events. Apheresis, on the other side, can dramatically reduce lipoprotein(a) concentrations and may be associated with reduced cardiovascular events, although the quantity is not quite clear yet. In patients with elevated lipoprotein(a), the most important strategy is to optimize other risk factors, especially LDL cholesterol, and in patients with progressive cardiovascular disease, despite optimal control of all other risk factors, apheresis may be a treatment option. And I firmly believe that further treatment options to reduce lipoprotein(a) and adequate outcome studies are urgently needed. Thank you very much.